Part A. Extract 1. Questions 1 to 12. You hear an oncologist talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. I'm Dr. Rosewood. Thanks for coming in today. Dr. Martin's referral mentioned some dermatological concerns and systemic symptoms. Could you elaborate, please? Take your time.
Oh, Dr. Rosewood, thank you for seeing me so promptly. I'm just at my wit's end, honestly. Where do I even begin? It started, maybe 3-4 months ago. A little speck. On my left forearm. Near the antecubital fossa, actually. I initially dismissed it as a persistent insect bite, one of those tenacious mosquito souvenirs. But it never went away. It got darker. Then it started to itch. Not just a mild, irritating itch, but a deep, almost maddening pruritus that would wake me up at night. I'd scratch it raw, despite my best intentions. Then, other spots started appearing. Smaller but still distinct. On my décolletage, too, which is just mortifying. They're all irregular, with sort of ragged borders, and a few have even started to bleed with minimal trauma. The one on my arm, the original culprit, has actually begun to ulcerate a bit. It's about 1.5 by 2 centimeters now.
I see. And accompanying symptoms? Any fever, night sweats, weight loss, Mihira?
Oh, absolutely. The fatigue is crushing. I feel like I'm dragging myself through treacle all day. I used to be so active, Dr. Rosewood. A keen amateur triathlete, mind you. Now, a walk to the mailbox feels like a marathon. And I've been having these intermittent fevers, low grade, usually peaking in the late afternoon, around 38.2 to 38.5 degrees Celsius. And the night sweats? They're drenching. I wake up absolutely soaked, practically needing to change the sheets. I've lost about 5 kilograms in the last 6 weeks, purely unintentionally. My appetite has been variable. Some days, I can barely stomach anything. Others, I'm ravenous, but the weight just keeps dropping. And my lymph nodes, particularly in my left axilla, feel a bit tender and swollen. I've been palpating them myself, probably obsessively.
That's a comprehensive picture, Mihira. And your lifestyle. Any significant sun exposure history? Travel? Occupation?
Sun exposure? Oh yes, heaps. I grew up in Queensland, Australia. Spent my entire childhood practically living on the beach. Fair skin, red hair, the classic Celtic complexion, a dermatologist's nightmare. Never really diligent with sunscreen in my youth, I confess. Moved to London for my university studies, then here to Dubai about 10 years ago. I teach English as a foreign language, so I'm indoors mostly now, but I still enjoy my weekend outdoor runs and occasional beach trips. I always try to be careful now. Factor 50 wide-brimmed hat, long sleeves, the works. But the damage, I suppose, was done years ago.
And Mihira, what remedies have you tried for these lesions? Over-the-counter creams? Anything topical?
Everything. My local pharmacist, bless her, suggested hydrocortisone cream for the itching, which did absolutely nothing. I even tried a colloidal silver solution my aunt swore by. Honestly, it just seemed to irritate it further. Then Dr. Martin prescribed a topical antibiotic, fusidic acid, just in case of secondary infection from all the scratching. It slightly alleviated the redness around the ulceration, but the underlying lesion remained unchanged.
Thank you, Mihira. That's a very thorough account. Based on what you've described, my preliminary suspicion, and we'll need biopsies to confirm this, points towards a melanoma. Specifically, the characteristics you've detailed particularly the irregular borders, varied pigmentation, ulceration, and rapid growth, are highly indicative. The swollen lymph nodes and systemic symptoms suggest potential metastasis, though we hope not.
Oh God. I had a feeling. My mother had a suspicious mole removed years ago, though it turned out to be benign.
We need to act swiftly, Mihira. The treatment plan will involve a surgical excision of the primary lesion, ensuring clear margins. Given the size and characteristics, we'll likely perform a wide local excision. We'll also need to perform a sentinel lymph node biopsy.
Extract 2. Questions 13 to 24. You hear a surgeon talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good afternoon, Mihira. Please, take a seat. What brings you in today?
Good afternoon, doctor. It's my knee. Again. But this time it feels different. Worse, somehow. It's the right one. It started subtly, maybe 6 months ago, just a dull ache after my shifts. But now it's a constant companion, this gnawing discomfort, particularly when I'm trying to ascend or descend stairs at the atelier. And kneeling? Forget about it. It's like 1,000 tiny needles are pricking the patellar region, radiating into my quadriceps and sometimes even down my shin. The worst is the giving way sensation. Just yesterday, I nearly tumbled carrying a bolt of silk, a rather precarious situation when you're dealing with delicate fabrics and sharp implements. It's not just the pain, it's the apprehension, the constant vigilance I have to maintain. It affects my work, my ability to focus on the intricate details of a bodice or the drape of a skirt. I'm a maison, a bespoke tailor, you see, and precision is paramount.
I understand, Mihira. So, this sensation of your knee, is that accompanied by any specific sound, like a click or a pop?
Occasionally, yes. A sort of grinding sensation, almost like crepitus, deep behind the kneecap. It's not loud, more of a tactile vibration if I press on it. And swelling, definitely. Not gross edema, mind you, but a subtle puffiness, particularly noticeable after a long day on my feet, fitting clients. I've been trying over-the-counter NSAIDs, ibuprofen mostly, and topical analgesics. My physiotherapist, bless her cotton socks, had me doing some quad strengthening exercises, focusing on the vastus medialis obliquus and glute bridges. They provided a modicum of transient relief, but nothing sustained. I even tried a knee brace for a while, but it felt restrictive and, frankly, rather unsightly under my work attire.
Right. So, you've been diligent with conservative management. Let's have a look. Could you extend your leg for me? And now flex it slowly. Does that elicit the pain, Mihira?
Yes, especially as I near full extension. There's a distinct lateral pull, almost as if my kneecap is being dragged outwards. It's quite unsettling.
Based on your description and this initial observation, I'm suspecting what we call patellar tracking disorder. It's quite common, particularly in individuals with your level of activity and the demanding nature of your occupation, where repetitive knee flexion and extension are prevalent.
So, what does that mean for me, doctor? Will I be able to return to my previous level of activity? And how long will this take to fix? My order book is piling up, and I can't afford prolonged downtime.
The initial approach will involve a refined physiotherapy regimen, focusing on strengthening and re-educating the surrounding musculature. We might incorporate some taping techniques to assist the realignment. I'll also prescribe a course of celecoxib to manage the inflammation. Typically, we'd expect to see significant improvement within 6 to 8 weeks. Any other concerns for now, Mihira?
Just the uncertainty of it all.
Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Now look at question 25. You hear a physiotherapist called Mihira talking to a GP.
Dr. Davies, thank you for taking my call. I'm ringing about Mr. Henderson, the gentleman with the chronic lower back pain, the one with the L4, L5 disc involvement we've been managing with conservative strengthening. He presented today with a new complaint, a sudden onset, quite intense, right-sided gluteal ache radiating into his posterior thigh, not past the knee. He mentioned a slight numbness in his foot too. I initially thought piriformis syndrome given the distribution, but the intensity is concerning, and he's unable to tolerate any weight bearing on that leg. It's distinct from his usual axial pain.
Ah, Mr. Henderson. Yes, I recall. So, this new pain. Is it positional or constant? Could it be a flare of his sciatica?
It's constant, Dr. Davies, exacerbated by any movement. And the numbness, while mild, is new. My primary concern is the sudden neurological component combined with the severe functional limitation. I'm leaning towards a potential disc extrusion now, possibly impinging on the S1 root, given the sharp, lancinating quality. I've advised immediate bed rest and cold packs, but I believe he needs urgent imaging.
Understood, Mihira. The sudden escalation and neurological signs are certainly red flags. I'll arrange an urgent MRI for him this afternoon.
Question 26. You hear a nurse called Mihira talking to a surgeon. Now read the question.
Dr. Harrison, do you have a moment? I'm calling about Mrs. Albright in room 214. Her post-operative recovery from the cholecystectomy was progressing quite well, minimal pain, clear fluids tolerated. However, overnight, her abdominal drain output has significantly increased, from 50 milliliters in the last 8 hours to 120 milliliters in the last 2. It's quite serosanguinous. She's also reporting a new, dull ache in her right upper quadrant, more pronounced than her initial incision discomfort. We've given her the prescribed paracetamol, but it's not touching this new pain.
Increased output and new pain, you say? Is she febrile, Mihira? Any changes in her vital signs, tachycardia, hypotension?
No fever, Dr. Harrison. Her temperature is stable at 37.1 degrees Celsius. Blood pressure is 118/72, pulse 88. Respiratory rate 16. The drain site looks clean, no overt signs of infection, but the sheer volume and change in character of the fluid, combined with her new pain, are my main concerns. I'm worried about a potential bile leak or, less likely but still possible, an internal hematoma given the drain's change.
Right, Mihira, that rise in output is definitely significant, especially the serosanguinous nature. A bile leak would be my primary suspicion here, given the cholecystectomy. I'll be right over to assess her. Prepare for an urgent abdominal ultrasound.
Question 27. You hear a head nurse called Mihira talking to the team. Now read the question.
Team, good morning. Just a quick briefing for today. We have a busy ward round. First, Mrs. Peterson in room 3. Her 4 access is still proving problematic, so let's try the dorsum of the hand again. Slow infusion this time. Also, Mr. Chong in room 7. His blood glucose levels are still fluctuating despite the adjusted insulin regimen. Please monitor him closely every 2 hours today. However, the most critical issue is Mr. Davies in room 12. He's showing increasing signs of confusion and disorientation. His family reported this worsening over the weekend, and his neurological observations are slightly declining. He's usually quite lucid, even with his dementia. I'm concerned about a possible underlying urinary tract infection given his age and recent catheterization, so I've already sent off a urine sample. We need to be vigilant for any further cognitive changes. So Mihira, closer glucose monitoring for Mr. Chong and another attempt at IV for Mrs. Peterson? Exactly. But my primary concern, and what I want everyone to prioritize, is Mr. Davies's escalating confusion. Keep a very close eye on his GCS and neurological assessments. This isn't typical for him.
Question 28. You hear a physiotherapist called Mihira talking to a neurologist. Now read the question.
Dr. Evans, thank you for taking my call. I'm ringing about Mr. Sharma, the gentleman with the cerebellar ataxia. His gait has been progressively deteriorating, as you know, with increased truncal instability. We've focused heavily on balance exercises and core strengthening, and while he's made some admirable gains in his static balance, the dynamic aspect remains challenging. However, what's prompted this call is a new symptom. He's now experiencing significant diplopia, particularly when looking to the left. This developed quite suddenly this morning. It's really affecting his ability to track objects and is causing considerable dizziness, impacting his already compromised ambulation.
Diplopia, you say? And sudden onset. Is it constant or intermittent? Any nystagmus accompanying it, Mihira?
It's constant, Dr. Evans, and it's a horizontal diplopia. We're also observing a noticeable nystagmus on leftward gaze. It's certainly more pronounced than the subtle gaze-evoked nystagmus he typically exhibits. This new visual disturbance, combined with the exacerbated dizziness, is severely limiting his functional independence. He nearly fell during our therapy session trying to navigate around a chair. My concern is a new lesion or progression affecting the brainstem or cranial nerves.
Yes, Mihira, that's a significant change. The sudden onset of constant diplopia with nystagmus in a patient with ataxia immediately raises concerns about a new demyelinating event or possibly a vascular incident. I'll need to see him urgently.
Question 29. You hear a nurse called Mihira talking to a doctor. Now read the question.
Dr. Khan, do you have a moment? I'm calling about Mrs. Jenkins in Ward C. She's been admitted with community-acquired pneumonia, and we've been managing her oxygen saturations with nasal prongs. Her chest physiotherapy is ongoing, and she's tolerating oral fluids well. However, over the last hour, her saturations have dropped from 94% to 88% on 4 liters of oxygen. Her respiratory rate has also climbed from 22 to 30 breaths per minute, and she's using accessory muscles. She's looking quite distressed now, and her cough is becoming less effective, more of a weak, wet sound.
That's a significant deterioration, Mihira. Is there any stridor or wheezing? Any changes in her level of consciousness?
No stridor or wheezing, Dr. Khan. She's fully alert and oriented, but she's clearly working hard to breathe. The drop in oxygen saturation and the increased work of breathing are my main concerns. I'm wondering if we should consider escalating her oxygen delivery to a non-rebreather mask or perhaps even high-flow nasal cannula. I've already prepared the non-rebreather.
Good thinking, Mihira. Given the rapid decline in saturations and the evident respiratory distress, a non-rebreather mask is definitely indicated. I'll be right there to assess her and review the chest X-ray.
Question 30. You hear a GP called Mihira talking to a community nurse. Now read the question.
Sarah, thanks for calling back. I'm ringing about Mrs. Thompson, the elderly lady in flat 4B who had that fall last week. Her mobility was already compromised, as you know, with the bilateral knee osteoarthritis, and she'd been struggling with medication adherence for her hypertension. She was discharged with clear instructions on gentle exercises. However, her daughter called this morning, very distressed. Mrs. Thompson has had another fall, this time resulting in a visibly deformed wrist. Her daughter found her on the floor, saying she felt dizzy and lightheaded just before it happened. The concern isn't just the wrist fracture, which I've arranged an ambulance for, but the underlying cause.
Oh, Mihira, another fall. Was it a trip, or did she just lose balance? I know her home environment is a bit cluttered.
Her daughter assures me the pathway was clear this time. She insists her mother specifically mentioned feeling dizzy and lightheaded just prior. Given her history of poorly controlled hypertension and previous episodes of near syncope, my immediate thought is that this fall was precipitated by a transient hypotensive event, perhaps related to postural changes. We need to investigate her blood pressure medication regimen.
So Mihira, a cardiovascular event, rather than environmental. I'll make sure the paramedics are aware of that history.
Precisely. The fractured wrist is secondary to the primary event.
Part C. Extract 1. You hear an endocrinologist, Mihira, and an interviewer on metabolic disorders of Generation Z. You now have 90 seconds to read questions 31 to 36.
Welcome Dr. Mihira, a leading endocrinologist with extensive experience in pediatric and adolescent metabolic health. Today, we're delving into a critical public health issue, the escalating prevalence of metabolic disorders among Generation Z. Dr. Mihira, thank you for being here.
It's a pleasure to be here.
Dr. Mihira, to begin, could you paint a picture of the current landscape? What particular metabolic disorders are we seeing more frequently in this younger demographic? And how does this trend diverge from previous generations?
Absolutely. What's starkly evident is the accelerated onset of conditions previously considered adult onset or even geriatric. Type 2 diabetes mellitus, once a rarity in pediatric clinics, is now almost commonplace. We're also witnessing a significant rise in non-alcoholic fatty liver disease, or NAFLD, often progressing to non-alcoholic steatohepatitis, NASH, at alarmingly young ages. Polycystic ovary syndrome, or POS, in adolescent females is also a growing concern, intrinsically linked to insulin resistance. This isn't just about increased body mass index, though that's certainly a significant contributor. We're seeing dyslipidemia, hypertension, and hyperuricemia occurring in combinations that suggest a syndromic presentation much earlier in life. The metabolic milieu of a Gen Z adolescent today often mirrors that of a middle-aged adult a generation ago, minus the decades of accumulated lifestyle insults. The trajectory is undeniably concerning.
That's quite a sobering observation, Mihira. Given this concerning trajectory, what, in your expert opinion, are the primary drivers behind this worrying surge in early-onset metabolic dysfunction? Is it solely attributable to dietary changes and sedentary lifestyles, or are there more nuanced, perhaps even epigenetic, factors at play?
It's rarely singular in a complex biological system, isn't it? While the ubiquity of ultra-processed foods, laden with high-fructose corn syrup and unhealthy fats, coupled with a dramatic reduction in physical activity due to pervasive screen time and urbanization, are undeniably colossal contributors. The narrative extends beyond simple calories in versus calories out. We cannot overlook the influence of the intrauterine environment, for instance. Maternal gestational diabetes or excessive gestational weight gain can program the fetus for metabolic dysregulation in later life, predisposing them to insulin resistance. Then there's the microbiome. Emerging research strongly suggests a pivotal role for gut dysbiosis in metabolic health. Furthermore, chronic stress, often amplified by social media pressures and academic demands unique to this generation, can induce cortisol elevation, indirectly influencing insulin sensitivity. So it's a multifaceted confluence: genetic predispositions, early life exposures, lifestyle choices, and indeed, the chronic stress response of modern living.
Fascinating insight into the complexity of the issue. When a young patient presents with these early signs, what are the initial steps in diagnosis and, crucially, Mihira, how you tailor interventions for this particular age group given the long-term implications?
Early detection is paramount. Beyond standard anthropometric measurements, we focus on fasting glucose, insulin levels, lipid profiles, and liver enzymes. Oral glucose tolerance tests are often necessary, and sometimes a liver ultrasound is needed to check for steatosis. Tailoring interventions for Gen Z requires a very different approach than for an adult. Compliance is a significant challenge. Our focus isn't just on weight loss, but on fostering sustainable lifestyle changes that prevent long-term complications. This involves not just dietary modifications, emphasizing whole, unprocessed foods and reducing sugary beverages, but also integrating regular physical activity into their daily routines. Critically, we engage the family unit. Parents play a vital role in shaping the home environment and supporting healthy choices. Pharmacotherapy, such as metformin, is considered when lifestyle interventions alone are insufficient, but it's always an adjunct, never a sole solution. Psychological support is also crucial, addressing body image issues and potential emotional eating, as these are often interconnected.
That collaborative approach sounds essential. Looking ahead, Mihira, what do you envision as the future implications for public health if these trends continue unabated? What proactive measures should society be taking to mitigate this metabolic health crisis?
The implications are profound and potentially catastrophic for healthcare systems globally. We're looking at a future generation burdened by chronic diseases at an unprecedented scale, increased cardiovascular events, kidney disease, liver failure, and certain cancers, all rooted in early metabolic dysfunction. This will place immense strain on resources. Proactive measures must be systemic. It's not enough to tell individuals to make healthier choices. We need policy-level interventions. This includes stricter regulations on food marketing to children, especially for unhealthy products, subsidizing healthy food options to make them more accessible and affordable, redesigning urban environments to encourage physical activity, perhaps more green spaces and safe walking/cycling paths, integrating comprehensive health education into school curricula from an early age, focusing on nutrition literacy and the importance of movement. Lastly, investing heavily in research into novel therapeutic strategies and early diagnostic markers. It's a societal challenge requiring a societal solution.
Dr. Mihira, your insights have been incredibly valuable. Thank you for shedding light on such a complex and critical issue facing our youngest generation.
My pleasure. The conversation is vital.
Now look at Extract 2. Questions 37 to 42. You hear an ENT specialist talking about the latest technology in use at the Mihira Research Institute. You now have 90 seconds to read questions 37 to 42.
Good morning, everyone. I'm Dr. Andrew Vance, an ENT specialist here at the Mihira Research Institute. Today, I want to talk about a groundbreaking advancement that is fundamentally reshaping surgical practice within our field, particularly concerning complex anatomical regions, the advent of AI-powered intraoperative navigation systems for endoscopic sinus and skull-base surgery. This isn't merely an incremental upgrade. It represents a seismic shift in how we approach intricate surgical landscapes. These systems integrate high-resolution preoperative imaging, think CT and MRI scans, with real-time instrument tracking, essentially providing surgeons with a dynamic, three-dimensional roadmap within the patient's anatomy, visible on a screen right in the operating theater. This augmented reality overlay allows for unprecedented clarity, especially in areas notoriously difficult to visualize directly, such as the ethmoid labyrinth or the sphenoid sinus. So, how do we rate this transformative technology? From my perspective, its effectiveness is nothing short of revolutionary. We've observed a dramatic enhancement in surgical precision, allowing for sub-millimeter accuracy when operating in close proximity to vital structures like the optic nerves, carotid arteries, and the brain. This translates directly into improved patient safety, significantly reducing the risk of iatrogenic complications. While there's an initial learning curve for the surgical team to become proficient with the system's interface and calibration protocols, the subsequent gains in efficiency and confidence are immense. It doesn't replace surgical skill but rather amplifies it, allowing for more aggressive yet safer tissue removal where indicated, or, conversely, meticulous preservation of critical structures. It's truly a paradigm shift in surgical execution, ensuring that Mihira care remains at the forefront of medical innovation. The importance of this latest technology cannot be overstated, particularly in the realm of rhinology and skull-base surgery. Historically, these procedures have been fraught with challenges due to the highly variable, and often complex anatomy of the paranasal sinuses and their proximity to cranial structures. Traditional endoscopic techniques, while minimally invasive, still relied heavily on the surgeon's anatomical knowledge and tactile feedback. Now, with real-time visual guidance, we can confidently navigate previously inaccessible areas. This capability is paramount when dealing with extensive sinonasal tumors or addressing cerebrospinal fluid leaks at the skull base. It minimizes the need for more invasive external approaches, reducing patient morbidity and accelerating recovery. This precision is central to our commitment to providing exceptional Mihira care. The key factors enabling the efficacy of these navigation systems are multifaceted. Firstly, data fusion, the seamless integration of diverse imaging modalities to create a comprehensive anatomical model. Secondly, the highly sophisticated optical or electromagnetic tracking systems that pinpoint the exact location of surgical instruments within that 3D space, updating instantaneously. Thirdly, the intuitive software interface translates this complex data into an easily digestible visual format for the surgeon. And finally, the underlying AI algorithms that refine spatial awareness and can even predict potential instrument trajectories based on learned anatomical patterns, contributing to the adaptive intelligence of Mihira care protocols. Ensuring the accurate use of this latest technology involves several crucial steps. It begins with rigorous preoperative planning, where surgeons meticulously review the patient's imaging on the navigation workstation, mapping out the surgical approach and identifying critical structures. Intraoperatively, a precise registration process is performed, linking the patient's anatomy to the imaging data. This involves identifying anatomical landmarks to create a reliable spatial match. Throughout the procedure, constant intraoperative verification of instrument position is crucial. Furthermore, continuous training and skill development for the entire surgical team are non-negotiable. Our Mihira care training programs emphasize simulation-based learning to ensure proficiency and safe integration of this technology into daily practice. Ultimately, the impact of this latest technology on patient care is profound and overwhelmingly positive. Patients benefit from significantly reduced surgical invasiveness, leading to less post-operative pain, minimal blood loss, and often shorter hospital stays. The enhanced surgical precision means a higher likelihood of complete disease eradication in cases of pathology and a reduced risk of serious complications, thereby improving long-term outcomes and functional preservation. For instance, preserving olfactory function or preventing vision loss during delicate skull-base procedures is now more achievable. This innovative approach elevates the standard of care we offer, directly translating to superior healing and a better quality of life for those receiving Mihira care.